Today's lecture will be on the thoracolumbar spine, its normal function, and some common clinical conditions. The thorax is the area of the body between the neck and the abdomen. It contains the thoracic vertebrae, the ribs, sternum, and houses the internal organs. I'd like for you now to think about your functional anatomy and the differences between the thoracic vertebrae and the lumbar vertebrae. Take a moment and jot down some specific characteristics of what you may remember about these joints. You can pause the video if you need some more time. The spinous processes of the thoracic spine are sloped inferiorly with almost a vertical overlap between T5 and T8. You will also see near T11 and T12 the spinous processes will become more horizontal as they transition to like the lumbar spine. Facet joints are aligned in the frontal plane, so this would encourage lateral flexion in this area of the spine. However, we have more lateral flexion at the distal end of our thoracic spine. Why do we not have it in the upper thoracic? That's right, because of the ribs. The ribs will restrict lateral flexion. There are also additional facet joints that are on the thoracic vertebrae and on their transverse processes, and yes, this is for the rib attachments. The thoracic spine is not as mobile as the cervical spine. As mentioned in the previous slide, the rib cage will limit lateral flexion, even though the facet joints are aligned in the frontal plane to promote lateral flexion. Also, the long spinous processes are going to limit thoracic extension due to the bony block of the nearly vertical spinous processes. The last two thoracic vertebrae do behave more or transition to like lumbar vertebrae. So not only are their spinous processes more in a horizontal plane, but the facet joints are more in the sagittal plane, which would promote flexion and extension in the sagittal plane. The lumbar spine is going to be made up of the largest size vertebrae. This is because of the amount of weight bearing that goes through the vertebral bodies at this distal end of the spine. Also, we have a lot of large muscle attachments. Their spinous processes are oriented in the horizontal, and their facet joints are in the sagittal plane to allow for greater flexion and extension in this area of the spine. Although the lumbar spine also does have a good amount of lateral flexion and rotation. Please review your ligaments as listed in Mansfield and Newman and your Norkin and White textbooks. As when we discuss the cervical spine, we have a lot of ligaments in the spinal area to provide stability, especially with all of the moving joints for protection of the spinal cord and the spinal nerves. Here is a review of your anterior trunk muscles or your abdominals. You see there pictured is the transversus abdominals, which can be a key stabilizer for the spine, as also known as an abdominal corset. The video you see listed on the slide I have posted under this module and gives you instructions on how to teach your patients to activate the transversus abdominis. The posterior trunk muscles have 3 layers. The most superficial we have discussed earlier in regards to the scapula. the trapezius, latissimus dorsi, rhomboids. These muscles are going to be all innervated by the anterior pubic rami. Then we have the intermediate level of posterior trunk muscles. And this, if you like the acronym I Love Science, going from lateral to medial, iliocostalis, longissimus, and spinalis. And then our deepest layer is going to be our spinal rotators, which we will see on the next slide. This slide reviews the deepest layer of the posterior trunk muscles, the rotators. The quadratus lumborum is also considered a posterior spinal muscle. It has attachments, or its origin is going to be at the transverse process of L1 and 4 through 4, as well as the 12th rib. And then its insertion is going to be at the iliac crest. Together or bilaterally, this muscle works to assist with trunk extension. Unilaterally, it can do a hip hiking, which is often a common gait deformity or compensation, especially with patients who have weak hip flexors, or if they are being maintained in a non-weight bearing status. If patients have a spasm or tightness of their quadratus lumborum, especially unilaterally, it can present as low back pain because of its attachment on the lumbar spine. If they are in symmetry, they will help to maintain the pelvis in symmetry. This is a quick review of the spinal nerves of the trunk. Remember that the spinal nerves begin T2 through T12 because T1 is part of the brachial plexus. And as they come out of the spinal cord, the anterior primary rami are going to innervate the skin and muscles in the lateral and anterior trunk, whereas the posterior primary rami will travel posteriorly and innervate the skin and muscles of the back. We will now review some common clinical conditions of the thoracic and the lumbar or thoracolumbar spine. Low back pain is the most common cause of disability in middle-aged working class adults, which costs about $50 billion in healthcare dollars each year. It is the second most common reason to visit a physician, or ED visits, second to the common cold. There are millions of dollars spent in missed work, and a lot of that in healthcare. Thinking of RNs and CNAs, therapists too. Hopefully you all remembered all about body mechanics that we've talked about so much during the program. But you can be helpful and instrumental in this in the clinic or in the hospital in helping to instruct nurses and CNAs how to maintain proper body mechanics while caring for patients. And low back pain is a very common diagnosis, and by common I also mean just general. It can be related to muscle strains, maybe a ligament sprain, a radiculopathy where there's pain traveling because of a nerve being pinched. So it can be a lot of things, and sometimes they will come to our clinics, an outpatient, and the diagnosis will just say low back pain, and you may not have anything more specific than that. As I stated in the previous slide, there can be multiple causes for the low back pain. One of the most common is a muscle strain, and typically this is the mechanism of injury is going to be when somebody lifts something heavy and not maintaining proper spinal curves and body mechanics, or they move sudden. And what it's going to be is often it's going to be the strap muscles or the erector spinate muscles, those being iliocostalis, longissimus, and spinalis. So if this muscle becomes strained, the first thing it's going to be to do is to reduce the inflammation and not to stretch it right away, just allow that muscle to rest. But then we do need to restore muscle flexibility and strength to help prevent further injury. as well as instructing these patients in core stabilization, maybe also looking at the hip and see if there's any restrictions at the hip as well. You can also have a ligament sprain. Again, it's the same type of mechanism of injury. There's either a sudden force or repeated force where the spine is not maintained in its natural alignment of the spinal curves. And here we're going to have to decide, depending on which ligament is impaired, to try to first initially protect the spine, so not to encourage motion in which that ligament is preventing or restricting. Also, it's going to be a lot of education for this patient as well, looking at core stability exercises and strengthening to prevent future injury. A radiculopathy, or a pinched nerve, where there is pressure being put on the nerve root, causes paresthesias, numbness and tingling down the extremities. They can have decreased deep tendon reflexes. They can even have a dermatomal sensory loss. A way of looking at it in the lumbar spine is doing what they call a straight leg test to see if that position increases their radicular pain. Then you could think that there's a herniated disc in the lumbar spine putting pressure on a nerve root. As discussed in thorax class, the goal is going to be to centralize the pain to the back. So it's not have the radicular symptoms into the extremities, but to be able to centralize it back up into the spine. A lot of times we think of McKenzie exercises to accomplish this goal. Lumbar intervertebral disc pathology, or a herniated disc. You can see in the picture to the right that the nucleus propulsus is herniated and putting pressure on the nerve root. This can happen to middle, young-aged adults. Often they're going to have radicular symptoms where they're going to have pain or numbness and tingling going down the extremities. And these symptoms will increase when a repeated directional movement is performed. So as PTAs, you are going to educate the patient that moving in the opposite direction will help to take pressure off of that nerve root and centralize the pain back into the low back and to remove it from the extremities. Again, as we mentioned in the previous slide, this would be an example of McKenzie extension exercises to centralize the pain. Once you have that pain under control, then it's going to be a matter of education on posture so that they maintain a proper postural alignment, and also core stabilization so that they can protect the lumbar spine from future injury. You'll want to not only just educate these in an exercise, but put it into their functional training. Have them cue their core while they are lifting a box from the floor. Try to have it be part of their day-to-day activities. Again, initially you can use modalities to decrease pain and edema and inflammation. Traction is usually quite helpful in this treatment. And again, just trying to really have these patients buy into having a home exercise program that they're going to continue throughout their lifetime. This chart lists the percentage of body weight pressure on the intervertebral disc depending on the position of the body. So obviously if we are standing in equal weight bearing alignment, 100% of our body weight is being gone through our intervertebral discs. But what I really want you to take notice is those there in red. So standing with a forward bend, so not standing totally upright, has 150% of our body weight. And then if we are bending forward in flexion while lifting instead of maintaining the curves in our spine, we are at 275% pressure of our body weight. So education is going to be key for these patients, and maybe showing them something like this, that the amount of pressure being put on their spine in these different positions, and then also teaching them ways that they can relieve it. So, supine will totally take the pressure off of their, or not totally, but only 25% of body weight. Spondylolysis is a bony defect, a fracture or stretch fracture of the pars interarticularis of the spine. As a reminder, that is on the lumbar vertebrae between the facet joint and the spinous process, and you can review this in your textbook. And then spondylolysis is actually then when a forward slippage of the superior vertebrae over the inferior vertebrae occurs. Usually this will occur at L4, L5, or L5S1. It happens when there's a bilateral bony defect of the pars articularis, and that there are 5 different types that can cause this spondylolisthesis, or that forward slippage. Type 1, and you can review these in your textbook as well, is something that it's congenital, so there's a malformation of the vertebral lumbar vertebrae. Then type 2 is the most common effect in people age 5 to 50, and it's usually a result of mechanical stress. So this would be the gymnast, the dancer, who does forces end range of extension. And then type 3 is more of the degenerative type. It's more common in the older population. It usually occurs because there's a loss of the ligament integrity, and so that allows there to be more forward slippage. Type 4 is a traumatic, so it's caused by trauma that they get an acute fracture. And then type 5 is pathological, so it's due to a bone tumor. They also have 4 grades, and the grade of it is really just talking about how far forward the vertebrae has slipped. So a grade 1 is 0 to 25%, grade 2 25 to 50, grade 3 50 to 75%, and grade 4 75 to 100% of forward slippage. Physicians, once this is diagnosed, are going to prescribe anti-inflammatories or NSAIDs, also maybe muscle relaxers, because these muscles are usually inflamed and shortened in order to try to protect the spine. Usually surgery was only going to occur with types 3 and 4, where it's 50 to 100% forward slippage, and they do this in order to decompress nerve roots, protect the spinal cord. So at this point they'll do a laminectomy, where they actually remove and then a fusion of the spine. So in PT, we're going to do education to prevent or avoid ballistic extension. So that being of when you think of a gymnast and they've just stuck their landing on the vault and they go further back into extension. So that type of motion. We're going to do a lot of core stabilization, so trying to have the abdominals then protect the spine. We're going to teach the patient about where is neutral. If they've been doing a lot of extension, that to them will start to feel like what is their normal standing posture. So trying to find what is a neutral pelvis, a neutral spine. We can do modalities to decrease pain and inflammation. Some of the more severe types may need to have bracing. And then we will try to educate and return to activity as possible. The bottom picture of the spine shows you a fracture of the pars interarticularis, and you can see that beginning of the spondylolisthesis, or the forward slippage of the vertebrae. You can see that we have, our body is designed that we have the iliolumbar ligament, which spans from the transverse process of L4 or 5 to the iliac crest. And that is going to prevent anterior translation of lumbar L4 and L5. So therefore, it does help to prevent spondylolisthesis. Do not get confused, but here is an additional condition, spondylosis, which is osteoarthritis of the spine or degenerative joint disease of the spine. They will have signs and symptoms of back pain. You may even see neurological symptoms or radiculopathies if the encroachment from the arthritis is on the spinal nerve roots. You may even see bone spurs or osteophytes. Sometimes even the spinous processes will fuse at certain levels due to the osteoarthritis. In physical therapy, we're not going to be able to make changes to the spine, but what we can do is educate our patients in core stabilization, helping them to find what is their neutral spine and be able to then activate their abdominal muscles to maintain this position and to prevent injury to their back. We'll also look at lower extremity flexibility. Can they maintain a neutral pelvis? You'll be able to use modalities to decrease any inflammation and pain. And again, it's going to be instructing that patient in a home exercise program that they will need to continue for their lifetime. Lumbar stenosis is a narrowing of the spinal canal, which then constricts or compresses the nerve root and can compress the spinal cord as well. We talked about this stenosis when we were talking about the cervical spine as well. So symptoms that our patients can feel because of the pressure on the nerve root is they can have a radicular ache or pain. And again, these symptoms will be going into the lower extremities because of the location in the lumbar spine. They can have the paresthesias, the pins and needles. It can actually be at a part where it's going to impair their motor function because of compression on the nerve of the spinal cord. And these patients will state that their pain will increase when they are in a fully extended or fully upright position. So often we will see these patients being walking in a more flexed posture. It is more likely that males are twice as likely as females to get lumbar stenosis, and it does usually occur later in age. Surgical management could be a decompressive laminectomy, where they remove that part of the lamina so that it takes the pressure off the spinal nerves. In PT, there can be conservative management where they just have physical therapy. And then we're going to do a lot of education talking about postural exercises, looking at core stabilization, trying to maintain that neutral spine, some physical conditioning, even some weight loss so that we'll take some of the pressure off, especially in that flexed posture that they tend to have. Looking at their lower extremity flexibility, if they've been adapting and having a more flexed posture, maybe now they've had some shortening of their hip flexors. So making sure that they have the flexibility in their lower extremities. We can also do modalities for pain or for some inflammation. We'll look at maybe some manual therapy of doing some soft tissue work to try to correct their position and their posture. And again, giving these patients an exercise program that they're going to do for their lifetime. Lumbar spine fractures often are a result of trauma, like a fall or a motor vehicle accident. They can be classified by the forces that are produced, whether it's a compressive force and compression fracture or flexion rotation. Also on what the bone deformity is, whether it's a crush fracture, wedge, burst, shear. Most common spinal fracture are compression fractures. And as our textbook lists, that 700,000 per year occur usually in the elderly, and it's usually caused by a forward flexion moment in a patient that has osteoporosis, so they have that weakened bone. And if you look at the picture of the spine to the right, you see the compression from forward flexion, and that it will cause a compressive force, which would then result in a fracture. And the thing to think about is that compression fractures can occur with movements that you don't feel are very forceful just because of the weakness of the bone. So maybe the patient is transferring to a bedside commode or to their wheelchair, and they just sit down a little bit harder than what is expected. That can result in a compression fracture. So if they are starting to complain of pain, it's definitely something that you want to report to the nurse and the physician so that it can be checked on radiograph. Oftentimes, once they've had one compression fracture, they're more likely to have another. So what can be done? They're going to be given pain medicine, anti-inflammatory. Also, something that is usually quite successful is the surgeon can do a vertebroplasty, which means that they actually inject bone cement into the vertebral body. That helps give that support, and it'll decrease the pain. In physical therapy, we're going to do a lot of core stabilization, teaching them where their neutral spine is, trying to not do excessive flexion, so we're not putting those compressive forces on the vertebral bodies. We're going to look at their posture and help to give them a more correct posture. We'll look at their flexibility of their lower extremities and do they have a neutral pelvis. We can also do modalities for decreasing of pain and inflammation. And with this being our elderly population, we might want to look at their balance as well, and strength training just so that they don't have another fall, and also strength training with a person who has osteoporosis is good for their bone health. Here are some things to consider when working with patients who have some type of lumbar spine diagnosis or impairment. You always want to be aware if the patient reports new symptoms or if their symptoms worsen. You want to notify the PT and maybe the physician if they have worsening of their peripheralization of symptoms, meaning worsening in the extremities, night pain, changes in bowel and bladder. Night pain is often one that you think of indicative with cancer, pain that's not relieving. Changes in bowel and bladder will make you think that there's more something neurological going on. Saddle anesthesia, meaning that there can be some of the spinal cord compression, and saddle meaning the area of the body that would be in contact with a saddle. For thinking about our patient with pain, a lot of times we're going to look and see what is their directional preference. If extension feels better or if flexion feels better, and then we'll have an exercise program that is designed around that direction of preference. Our patients that do end up having surgery, we do want to make sure that we teach them early on how to do log rolling, so we're not putting increased strain or stress on their spine as they transition from supine to sit. Or to also teach them how to do splinted coughing so that they are able to clear their secretions and not develop any post-op complications. Once they're able to really participate in therapy, we want to make sure we're doing all of their functional activities and closed chain activities in a neutral spine. And that will be just a lot of education to make sure that they understand what is neutral spine. Can they do a pelvic tilt? Can they go anterior to posterior and then find what is neutral? And then also, making sure that we look at their functional exercise. Are they have good endurance? Do we need to get them on some just general endurance type of activities? And then looking at their posture and also their function to see if there's anything that we can give further education. There are back schools we see in the community, which is more of a back injury or prevention program. A lot of times this can be connected with a workplace. It may be something where you're asked to go ahead and teach a class in body mechanics or ergonomics. Be interesting to see if any of you do that while you're on your clinical rotation. Muscle injury to the muscles surrounding the thoracic spine can be a result of a direct contact, maybe a contusion during a sporting event, or indirect overstretching, rotation, where the muscle becomes contracted more as a protective mechanism of that area. We see it more often in our younger and active patients. The medical management of this is going to be for pain control, decreasing any inflammation, so they may be prescribed some anti-inflammatories. In therapy, we'll want to use modalities that are going to decrease pain and also inflammation. We're going to do some active stretching and strengthening of those muscles. Looking at the patient's posture, is there any education we could give about posture, or maybe how they do some of their functional activities? We're also going to look at the lumbar extension and cervical as well, and see if there needs any education in other areas of the spine. Doing core stabilization, strengthening of the muscles in that area, and we'll be looking at our scapular stabilizers again when we're talking about the thoracic spine because of their attachments. We may need to do some manual therapy, doing some soft tissue work to help release maybe any muscle that might be in spasm, and again we're going to educate our patients in a home exercise program. We can also have a herniated disc or disc pathology in the thoracic spine, although it is much less common than occurring in the lumbar spine. Because of its location in the intercostal nerves, patients can have referred pain anteriorly to the chest. They can also have radiculopathy down their lower extremities as well. We will want to try to centralize the pain into the thoracic spine by doing their directional preference. Also will be included in McKenzie exercises, usually used to centralize the pain. We will also want to educate in posture and core stabilization, and then making sure that they're able to maintain a neutral spine and their core stabilized while performing their functional activities. We can also utilize modalities for pain management, decrease inflammation. Again, traction is going to be good for this type of patient, and we will also have them on a home exercise program that they should be on for their lifetime. Kyphosis is a posture that is identified by a thoracic convexity, which you can see in that picture to the right, and what goes along with that is rounded shoulders and protracted scapula, which we already know from talking about the shoulder and our scapular stabilizers and that scapular humeral rhythm, that having a kyphotic spine is going to impact our patient's range of motion at their shoulder. Kyphosis can have three different categories: congenital, meaning they're born with it; neuromuscular, so developing from some type of either nerve impairment or muscular weakness; or postural, habitual. It can also be caused of patients, if we talked in the earlier slides, that had osteoporosis and has had repeated compression fractures, so that anterior shift, and that could cause a more of a permanent change in posture. These patients are going to have some pain, and you'll see too that they'll have some stretching of their posterior longitudinal ligament, their erector spinate muscle, as well as their rhomboids, since their scapula will be protracted. They can have a surgical intervention where they go and have a kyphoplasty if it is due to the compression fracture, so they can build up those vertebral bodies. In physical therapy, we're going to look to try to strengthen anything that is already being stretched. So those rhomboids, erector spinate, trying to get them more into that neutral alignment of the spine, which, depending on how long they have been in kyphosis, may or may not be possible. They may be able to use some bracing. We're going to try to encourage them to participate in a home exercise program daily and try to be more aware of their posture, especially when they're during function, and anything that we can do to change their workstation or to make it more encompassed into their workday, as well as trying to use modalities or our pain and stretching instruction to try to decrease any pain that they may be having. Scoliosis is a lateral curvature of the cervical, thoracic, and lumbar spine. It's usually idiopathic, meaning we don't know the cause. And there are two types. There's structural or functional. Structural means that it is fixed and does not resolve, versus functional is reversible. As we have our patient flex forward, the curve will resolve and not be pronounced. A lot of times these patients will have pain because of the shift of their spine. Also cosmetics. They want to, as it would progress, they don't want to have that concern as their curve would increase, the look that presents. Also, we have to think about cardiopulmonary function. If we have a curve that's greater than 65%, are they going to be able to breathe, and are their lungs going to be able to expand? Depending on the severity of the scoliosis, a surgeon may go ahead and insert Harrington rods or perform spinal fusion to try to stop or correct the scoliosis. Patients can also be placed in a brace, either a Milwaukee brace or a TLSO brace that will encompass the entire spine to try to help them get better alignment. In physical therapy, we're going to look on trying to stretch the muscles of the concave area of the spine and then strengthen those of the convex. We'll try to use these exercises also to decrease their pain, making them more aware of their posture. And if they do have surgery, we'll be involved in that early process too, and teaching them how to do log rolling and to do their other functional activities. Some other things to consider as we're talking about the thoracolumbar spine is that it houses our areas, muscles of respiration. So just having a review there of the muscles for inspiration, expiration. When you get into rehab course in the fall, you'll talk about how to teach your patient how to do a functional cough that have lost some of this musculature. Also to be aware of that our pelvic floor muscles, and as a PTA, you cannot really be involved in this area of physical therapy, but knowing that it exists and can help direct your patient if they're having weakness in that area.